Can you hear me?
Dr. Kim,
I'm Hyo-Sookim. Yes.
welcome to the.
I'm
You are live
Hyo-Sookim
at the
from
Coronary
SNU
Theater.
Hospital. Yeah, I know. Can I start?
Yes, please.
Okay. Welcome to SNU Hospital. I'm Hyo-Sookim. My co-operator, Dr. Han, JQ Han, Dr. Yang, Hanmo Yang, and my excellent colleagues. Can you see the slide? I prepared the calcified lesion for the first case of SNU Hospital. Slide next. 73 years old male. Chief complaint was chest pain on exertion, functional class 3 since 1 year ago. Diagnostic CT was done in the other hospital, and they detected carotid lesion instantly. He has all risk factors and peripheral artery disease with PTA 3 years ago. Plus, X-ray normal, plus ECG unremarkable, plus echocardiograph shows normal LV size and function, plus this is transfemoral cerebral angiographic finding in our hospital. We can see severe stenosis at both proximal internal carotid arteries. Plus, neurosurgeons plan carotid artery stenting, but they emphasize that coronary revascularization must be preceded before the carotid intervention. That's the reason why we first coronary intervention before carotid intervention. Plus, angiogram took last month. We can see diffuse, heavily calcified lesion from left main to mid portion of LAD, as well as lesion at proximal part of circ. Plus, spider view, see the critical stenosis around left main bifurcation with head calcification. Plus, caudal view, the same finding. You also take the angiogram today. Can you see the angiogram taken today, this morning?
Yes, we can see.
angio로 바꿔주세요. Okay, this is the angiogram taken this morning, 10 minutes ago. The same diffuse calcified lesion from left main to mid part of LAD, plus other cranial view. This LAD is okay. Lesion extends until the mid portion of LAD, plus epicranial view, the same finding, plus other cranial view. You can see the lesion at circ, plus spider view, both lesions at proximal LAD and proximal part of circ. More severe at proximal LAD, plus epicaudal view, plus okay, this is the angiogram taken together this morning. Is there any question or comment regarding the plan of this lesion? Yeah.
Dr. Kim, this is Moon Kyung Hong. My question would be, what would be the goal of intervention today? Would it be just to revascularize it sufficiently for the carotid surgery, or would you try to do complete revascularization? And the reason for this question is that
I prefer total revascularization.
I see. Then would you implant bare metal stents, or what would be the selection of stent type?
They do not perform a neurosurgery, just they plan to carotid intervention using stenting. Thus, I prefer metal DS to BMS in this case.
This is Sam
The discussion point is the strategy to treat calcified lesion. do we have to use rotablator or cutting balloon before conventional balloon angioplasty and stenting?
Dr. Kim, there's a comment from Dr. Simkus.
Because, yeah.
So mic on? Oh,
Yes.
sorry. I just wanted to make sure, would you let us know what the status of the right coronary artery is? Is that normal or is that also diseased? Because that may impact the hemodynamic status of the case.
Just a mild lesion at proximal part and mid part. Mild to moderate lesion, insignificant. Okay, we first took IVUS. Can you see the IVUS before anything done? This IVUS finding naive left main to proximal LAD without any intervention. I tried to use rotablator. Thus, if it's possible, I'd like to see the minimal lumen diameter to select both sides. This is IVUS from the mid part of the LAD. Can you see the IVUS pullback? IVUS interpreter is Dr. Eun-Seok Shin from Ulsan University Hospital.
Yes, this is already IVUS pullback image. This is a distal.
Okay, 이제 나.
Distal reference vessel. The lumen is 2.0 millimeter and vessel size is 2.5 millimeter. And you can see the eccentric superficial calcium, the fibro-calcified huge eccentric flag. And however, the lumen size is maintained the whole IVUS pullback. The size is 2.0 millimeter, and vessel size is 3.0 millimeter. Here is this mid-LAD region. Compared to IVUS coronary angiogram, in the IVUS, the superficial calcium and calcified flag is not severe, but it's almost the superficial calcium and huge amount of fibro-calcified flag.
심한 부위가 보여줍니다.
It's more proximal part. The flag is also the eccentric calcified flag, but the lumen area is also consistently maintained, 2.0 millimeter. Okay, this is a proximal LAD site. Fibrocalcified flag is much increased, but lumen area is maintained. This is the LAD ostium. The lumen area is 2.6 square millimeter. And this is ostium of left circumflex artery is coming up at one o'clock direction. After that, fibrocalcified flag is much increased, and that is encircling in the left main vessel. However, the lumen area is maintained. The lumen area in left main is 30.1 square millimeter. So whole lesion length is 44 millimeter. However, in the distal reference vessel have a significant plaque, so maybe the lesion length is much longer than IVUS pullback length. So, and in the summary, there is a huge amount of plaque in the mid-LAD whole length, but the calcified region is much severe in the more proximal site, and especially in left main. However, the lumen area is maintained up to 3.0 square millimeter.
So it looks like the circumferential calcium more than 2 270 degrees only in the left main. The proximal and mid LAD is the calcified but not circumferential. Is that right?
Yes.
Yeah, right.
And the narrowest lesion is around LAD ostium and left main distal part or proximal LAD. The diameter is about 1.6 millimeter. Thus, I tried to use a rotablator with both sides 1.75 to make the lesion well prepared for full expansion of future stenting. This is the angio taken just at the start of IVUS fullback. Thus, please remember the IVUS examination started at that point, the distal end of calcified lesion, plus, and I performed rotablator. First, I switched to the rotablator wire using microcatheter, plus. Then I used the 1.75 French millimeter burr using 7 French guiding catheter with side hole, plus. The second rotablation was performed until the part of distal LAD. And then we perform IVUS examination once again. Can you see the IVUS more quickly because of insufficient time? IVUS once again.
Okay.
Are you prepared?
Yeah, yes. This is an IVUS after rotablation. This is the distal reference vessel.
We
vessel size
cannot
is
see the IVUS image,
5
please.
millimeter.
IVUS 주세요. 큰 화면으로. 그 스위처 하는 사람이 잘 못하네. 자, IVUS in the
Okay,
big
this
screen.
is I was finding after rotablation, and this reference is 2.5. It's not changed, and we can see the eccentric flag, fibro-calcified flag. It's not changed in distal LAD. The lumen area is also not changed. In distal part is 2.0 square millimeter. The flag is also it's very similar before rotablation. In the proximal part, yes, we could, we can see some irregular luminal margin, but the lumen area is the same, 3.0 square millimeter. Here is the proximal LAD, and yes, circumflex ostium is coming up in 12 o'clock direction, and here is the left main. However, we couldn't see any evidence of rotablation. The lumen area is quite similar before rotablation.
I'm Dr.
And
Na.
whole lesion length is 50 millimeter.
OCT is, I think OCT is better than IVUS. NGO로 바꿔주라고. NGO, please. This is NGO after rotablation. Among 5 imaging tools for coronal lesions, OCT would be the best for calcified lesion because OCT is better than IVUS in resolution to assess the 2 things. The first one is angle of arc of calcification. When arc is more than 220 degrees, we can make a calcium crack with ballooning. That is very important for the future stenting to get optimal area, minimal area. The second factor to predict the calcium crack is thickness of calcium. If it is less than 0.67 millimeter, it is easier to make calcium crack with balloon. Thus, when we assess the calcified lesion with OCT tool, we can measure the arc of calcium and thickness of calcium. When arc is really broad and thickness is thick, then we have to do kind of low ablation to make the thickness thin. Then we can make easily calcium crack with pre-ballooning. Then we can get best, widest area after stenting. But in this case, I think the lesion is not so critical. Thus, even we don't need rotablator, just using simple balloon or cutting balloon. But for the easy passage of stent, I just prepare the lesion with a little bit big as the first rotabur, 1.75 millimeter. This is the angio after rotablator, plus a little bit better. The lumen is more smoothened before. This is a caudal view. I think there are two preparations required for this patient. The first one is rotablator for smaller vessel size of LAD. But left main calcium arc is more broader, but size is large. It does not require rotablator. Thus, I prepare the left main calcified lesion with cutting balloon with bigger size, such as 3.0. Okay, 3.0 cutting balloon. It depends on the anatomy and patient's status. For these patients with critical stenosis, both internal carotid artery, I don't like to permit even transient BP reduction. That's the reason why we put pacemaker. In the lesion aspect, if the vessel is very big, then I usually prefer backup of a pacemaker. When I perform a rotablator for the lesion at distal or mid part of LAD with relatively small size, we don't need pacemaker backup. Thus, it depends on the lesion. But pacemaker backup is not a cumbersome procedure. Thus, for the safety of patients, I strongly recommend my junior doctors to use pacemaker backup. Okay, I performed the cutting balloon inflation at the left main.
What's the pressure?
Just once again, inflation, dye injection.
6.
Shoot. Deflation. No. It takes a lot of time with few information.
As you
Okay,
mentioned,
I do a pre-deal for LAD with balloon 2.5 with maximum pressure. And just stenting from left main to mid to distal junction of LAD. And see the circumflex. Circumflex has also a lesion, inflation.
6. 6.
Deflation. Inflation. 12.
12.
Deflation. Inflation. 12. We can see full inflation of the balloon after rotablation. Deflation. But if there is a hard calcific nodule, we can see the indentation.
Yes,
But rotablator make the surface smooth. Inflation maximum.
18.
It's good expansion. Left main. Deflation. Okay. 다이 좀 아까 엔주 줬는데 밀어넣지. Okay. So let's see the angio. Shoot. Okay, it's good. Then I think it's time to deploy the stent. The age of these patients is about more than 75. Thus, I don't think it is necessary to deploy BRS. The life expectancy of Korean male is about 78 years old. Life expectancy is very important to determine the procedure, TAVI or BRS implantation. usage of TAVI and BRS depends on the remained lifespan. Okay. Which stent do we have to use as SNU hospital? Professor Zhang, what kind of stent did you decide for us to do? The organized committee decided that we have to deploy Onyx. Okay.
I think Onyx is one of the best
I'd
stents.
like to deploy the first at distal part, 2.75 or 3. Which size?
2.5, I think, for the distal.
Okay.
How do you think?
0.75.
What was the size of the guide? I didn't get
The
that.
bigger is better.
The 7
so I'd
guiding
like
is same French?
2.75. Yes, 7 French. 얼마죠? 길이가? 38. 오케이. 그 밑에는 33? 네. 오케이, 33. Like I'd like to deploy 32 millimeter long, 2.75 Resolute Onyx. Onyx is a very interesting stent because for this such kind of heavily calcified lesion, the visibility is very important. Onyx has the excellent visibility like Promus Premier, platinum chromium. I have to cover the left main ostium, thus radial opacity of stent is very important for me to make the proximal edge of stent exactly at the left main ostium. That's the reason why I chose Resolute Onyx or Promus Premier. Premier has a weak in terms of longitudinal shortening. Thus it is not appropriate to deploy the stent at ostial lesion test. Test it. Okay, inflation.
4, 8, 12입니다.
I target the distal edge of stent just before the third diagonal branch. I usually perform inflation up to 20 seconds. And to make sure the even inflation, no indentation. Once again, inflation.
12입니다.
Once again, deflation. When you inflate the stent just 5 seconds, it cannot reach the nominal diameter. Angel? Okay, this is the results after first distal stenting. Okay, welcome again, SNU Hospital. The last image, please, Angel, please, was just immediately after the first stenting from proximal LAD to mid to distal junction LAD. This is Onyx 2.75 by 34 plus. This is a caudal view. We can see the remaining severe stenosis from left main to proximal LAD. Then I chose Resolute Onyx 3.5 by 26. Okay. So left main ostium coverage is very important. This is caudal view. Plus, and we can see the approximation of proximity between the left main ostium and proximal edge of stent. Plus the spider view, a little bit withdrawal of stent would be the ideal position to cover the left main ostium. It is important to check the secure coverage of ostium at least 2 different projections, caudal or cranial, or right caudal and spider view. Plus, a little bit withdraw stent, then the mark is outside of left main and inflate. We can see the indentation because of encircling calcification at left main body here, requiring adjunctive ballooning. Plus, this is cranial view. We can see the remaining stenosis at left main body because of encircling calcification. Plus, and then left circumflex ostium is compromised. Plus, then I put the wire into the circumflex. Plus,
답 들어가시죠.
and then plus, I perform 2.5 balloon maximum inflation at the ostium of circ. Plus,
CT 확보해. 네.
then I perform the adjunct balloon of left main with NC balloon. Plus, full dilatation was confirmed, 3.5 NC balloon. Plus, ostium once again, full dilatation. Plus, angio, we can see full dilatation of left main body. And we can see also there is a residual lesion of proximal circ that is heavily calcified. Then we have to do repeated ballooning. Plus, once again, maximum inflation at the ostium. Plus, but a stent cannot pass through the proximal LAD, calcified lesion. Plus, thus I perform NC balloon 2.5 and repeated inflation. Concern is perforation. Thus, I usually increase the pressure, seeing the disappearance of indentation with repeated inflation with various atmosphere. Plus, once again, still indentation remained. Plus, still, plus, indentation starts to disappear. Plus, okay, this is angiogram after repeated inflation of proximal circumflex with 2.5 NC balloon. Plus, then it was possible to pass 2.5 onyx stent through the proximal lesion to the distal circ. Plus, this is plus, minus. Okay, this is the progress that we have achieved until now. Then I put the second stent at the proximal circ to do T-stenting. For this technique, I usually put the balloon at the main vessel first. And then this 2.5 by 18 tested. Okay, length is good. Another view, spider. Seen it? Sure. How do you think about acceptable?
It looks good.
Okay.
We are going to do the
Counter
tab,
once
right?
again. Yeah. Once again, angio. Sure. Okay, inflation.
4, 8, 6입니다.
Should. Okay. There's still slight indentation at proximal circ, calcified lesion. How much is the pressure?
12.
12.
너무 높아.
How long? Seconds? Okay, deflation. Then I try to do once again the inflation, slight withdrawal. Okay, inflation, 14.
14.
Deflation. $12, 14.
14.
Okay, deflation. Then I'm going to kissing ballooning. 야, 이게 발롱이 짧다, left main이. 오스티움까지 커버가 안 되네. 오케이. 테스트. Okay, inflation.
네. 2, 4, 6, 8.
Shoot. 저장. I covered left main ostium during kissing ballooning. Deflation. Okay, we can see the left main ostium well. Sure. Apicranial. A little bit twist.
오스보이.
Okay. 네. Shoot. Spider view.
Dr. Jung, is that also the angle that you normally use? It normally depends on the orientation of the left main to the aorta, and
Right.
yeah,
Right.
or often I think the LAO crania, epicrania, or the LAO should maybe
아이브스 안 하시겠다.
the junction a
강력한.
little bit
So
better.
usually
But
they-
what is your usual angle?
Right, right. I think they
Okay, minus.
usually the ostium of the left main starts to
Minus.
like left 110 degree,
Minus.
more than 90 degrees. So maybe LAO 30 will be the tangential view for the normal left main, but it's depending on the
Hold on.
patient.
Yeah.
Okay, this is spinal angio. Aerial caudal view, we can see the left main, proximal LAD, proximal circ. Proximal LAD, we can see a little bit insufficient dilatation, but that size is about 3.5. We can do adjunctive ballooning at that area. Circumflex is fine, although there is a little bit indentation at proximal circ. I'm concerned about overinflation further would lead to coronary perforation. Thus, I'd like to restrain overinflation at the circumflex. LAD, we can do adjunctive balloon once again, plus. This is our cranial view. At this view, proximal LAD looks fine, suggesting proximal LAD lesion was eccentric, plus. Here, we can see the proximal LAD looks good, plus. Because the left main is all covered by stent, well inflated. Thus, how many minutes remain? If time is sufficient, we can do IVUS.
I think we only have maybe 2 minutes of
Okay, more than 10,
transmission left here.
not 30 minutes, just 2 minutes.
Yes.
Then it was, the wire is all destroyed.
Would you like to image the ostium of the circ?
Pardon? Say again.
I'm sorry?
I said, would you like to image the ostium of the circ?
He's going to the IVUS in LAD and to see the proximal
which?
LAD as well as the bifurcation.
Okay.